Good morning. Good
The
morning.
doors open
Are you checking
automatically.
in to see the
You
triage
walk
nurse?
in,
How was your
and the
day
first thing you notice
then?
is that nobody runs.
Okay.
No one is
Any
rushing.
nausea or dizziness?
No one is shouting. The waiting room is full. The desk is staffed. People are moving, but with a specific, deliberate kind of speed that does not look like what you expected. You expected chaos. What you walked into is a system. This is the American emergency room. Not the one on television, the real one. And the United States has approximately 6,000 emergency departments operating across the country. Together, they handle more than 145 million visits per year. That is roughly 400,000 visits every single day. Every hour, across the country, more than 16,000 people walk through an emergency department door. The first person you encounter is the triage nurse. Not a doctor, not a receptionist. A registered nurse with specific training in emergency triage assessment. What their job is to determine one thing in the first 90 seconds. How sick are you right now? And what will happen if you wait? They use a standardized 5-level system called the Emergency Severity Index. Level 1 is immediate. Resuscitation required. You go directly back. Level 2 is emergent. High-risk situation, severe pain or distress. You are seen within minutes. Level 3 is urgent. Level 4 and 5 are less urgent. Minor problems that need attention but are not immediately life-threatening. The triage nurse is not deciding your diagnosis. They are deciding your priority. And that decision, made in 90 seconds based on vital signs, chief complaint, and clinical appearance, determines everything that happens next. Behind the triage desk, the emergency department is organized into zones. The acute care zone, resuscitation bays, trauma bays, high acuity treatment rooms, is closest to the entrance and to the imaging suite. The acute zone is designed for speed. Everything a critically ill patient might need, crash cart, ventilator, ultrasound, rapid infuser, is within arm's reach of every bed. The mid-acuity zone handles the majority of patients, fractures, infections, chest pain under evaluation, abdominal pain, neurological symptoms requiring workup. The fast-track zone, present in most large EDs, handles lower acuity cases, lacerations, minor injuries, uncomplicated infections, medication refills for patients without a primary care provider. The charge nurse is the operational center of the emergency department, not the attending physician. The charge nurse manages patient flow, tracking every bed, every patient status, every pending test result, every incoming ambulance, every anticipated admission. They are looking at a department-wide whiteboard, physical or digital, that shows the real-time state of every room, occupied, pending labs, pending imaging, ready for discharge, boarding, admitted but no inpatient bed available. And the charge nurse is solving a continuous resource allocation problem, matching incoming patients to available capacity in real time. The attending physician works differently than most people expect. In a busy emergency department, an attending physician may be simultaneously managing between 15 and 25 patients at different stages of their workup. They are not sitting beside each patient. They are moving, ordering tests, reviewing results, re-examining patients whose condition has changed, consulting specialists, making admission decisions, and writing discharge instructions. The emergency physician's skill is not the ability to focus on one patient. It is the ability to manage simultaneous uncertainty across many, knowing which patient needs them now and which can wait 10 more minutes. The nursing staff are the continuous presence at the bedside. Emergency nurses manage medication administration, IV access, specimen collection, vital sign monitoring, patient education, and the real-time clinical reassessment that catches the patient who is getting worse. In a high-volume emergency department, a nurse may be responsible for 4 to 6 patients simultaneously, each at a different stage of care, each with different needs, each capable of deteriorating without warning. The experienced emergency nurse does not wait to be told a patient is worsening. They notice before the numbers change. The testing workflow is one of the most misunderstood aspects of the emergency room. When a patient presents with chest pain, the workup includes an electrocardiogram, which must be completed within 10 minutes of arrival for chest pain patients. Blood tests, troponin, metabolic panel, complete blood count. Coagulation studies, drawn, transported to the lab, processed, and resulted. Imaging, chest X-ray at minimum. CT angiography if pulmonary embolism or aortic dissection is in the differential. Serial troponin testing. A second blood draw at 3 hours to detect a rising troponin level that the first draw might miss. This process takes time, not because the department is slow, because the biology is slow. The troponin level in a heart attack does not peak immediately. You cannot rush the biochemistry. The waiting room is a clinical space. This is not how most patients experience it, but the triage nurse and the charge nurse are watching the waiting room continuously. A patient who was triaged as level 3 an hour ago can deteriorate to level 2. The experienced triage nurse reevaluates waiting patients at regular intervals. They are not ignoring the waiting room. They are monitoring it. Boarding is the most significant operational challenge facing American emergency departments today. When a patient needs to be admitted to the hospital but no inpatient bed is available, they stay in the emergency department. They occupy an ED bed. They require ED nursing care. And they block the capacity that would have received the next incoming patient. On a typical day in a busy urban emergency department, between 20 and 40% of ED beds may be occupied by admitted patients waiting for inpatient beds. The emergency department is not backed up because of what is coming in. It is backed up because of what cannot leave. The consultant system adds another layer. But when an emergency physician determines that a patient needs specialist evaluation, cardiology for a complex arrhythmia, neurology for a new stroke presentation, surgery for an acute abdomen, a consultation request is placed. The consultant may be in the hospital or may be on call from home. Their response time, their assessment, and their admission or discharge recommendation all affect how long that patient remains in the emergency department. The emergency physician manages the patient until the consultant takes over, and then continues managing everyone else at the same time. Discharge is not the end of the process. It is a clinical decision with documentation, medication reconciliation, follow-up instructions, and patient education requirements that can take 30 to 60 minutes per patient. A patient who is medically ready to leave at 2 in the afternoon may not be physically out the door until 3, because the discharge instructions require a nurse's time, a prescription requires a physician's signature, and the transport requires a wheelchair and a staff member. And every bed that takes an extra hour to turn over is an hour that the next waiting patient does not have a room. The emergency department you walk into on a Tuesday afternoon is not the same as the one at 2 in the morning on a Friday. Volume changes, acuity changes, staffing ratios change. But the system, the triage, the zones, the charge nurse, the testing protocols, the consultant system operates continuously. 3 in the morning, 3 in the afternoon, holiday weekend. But flu season surge, the doors open, the system receives what comes through them. The American emergency room is not perfect. It struggles with boarding, with staffing shortages, with patients who have no other access to care, and with a volume that has increased every decade since the emergency department became the safety net of American healthcare. But it is also one of the most sophisticated real-time operational systems in the world, designed to receive anyone at any hour with any problem, and to begin the process of figuring out what is wrong. The doors never close. If you want to understand how American healthcare actually operates, the systems, the protocols, the people, and the infrastructure that runs 24 hours a day, consider subscribing to Health Systems USA and tell us in the comments, have you ever been to an American emergency room? What surprised you most about how it worked?